Good morning, everyone. I hope you all can hear me. So let me start with my presentation. So in the previous classes, I have discussed about the embryology of the nose and the paranasal sinuses. So today's my topic is about the anatomy and the physiology of the paranasal sinuses. So what are these paranasal sinuses? The paranasal sinuses are the air-filled sacs that are found in the skull bone surrounding the nasal cavity, and there are four paired sinuses present in the skull bone. They are maxillary sinuses, ethmoidal sinuses, frontal sinuses, and sphenoidal sinuses. So this is the coronal section where you can see the frontal sinuses bilaterally with ethmoidal sinuses multiple and maxillary sinuses bilaterally. And in the sagittal section, you can see the sphenoid sinuses which are located posterior to the frontal and the ethmoid sinuses. So first, let us start about the discussion about the maxillary sinuses. So maxillary sinus is otherwise known as the antrum of Highmore. It lies under the cheek and it is the largest of all the sinuses, and the capacity of the maxillary sinus is about 30 ml, 15 ml in each of the maxillary sinus. So this is the maxillary sinus which is lying just below the orbit over the cheekbone. Okay. So coming to the base of the maxillary sinus, the base of the maxillary sinus is otherwise known as the medial wall. It corresponds to the lateral wall of the nose here. So this is the base of the maxillary sinus, and this base of the maxillary sinus is otherwise known as the medial wall, which is corresponding to the lateral nasal wall. The central portion of the base is very much thin, and the natural ostium of the maxillary sinus is present in this wall. So this is the natural ostium, which is present in the thin base of the maxillary sinus or thin part of the medial wall of the maxillary sinus. So coming to the anterior wall of the maxillary sinus corresponds to the facial surface of the superior maxilla, and it is 2 mm thickness over the canine fossa. Coming to the posterior wall of the maxillary sinus, this is very much thick area and it is formed by the body of the superior portion of the maxilla, and this posterior wall is also known as the temporal surface. Coming to the roof of the maxillary sinus is formed by the thin orbital wall. This orbital wall is traversed by the infraorbital foramen, which is very much fragile wall. So any disease process in the maxilla is likely to affect the orbit through this wall. So this is the maxillary sinus. If this is the medial wall or the base of the maxillary sinus, this is the roof of the maxillary sinus, which is formed by the floor of the orbit. The floor of the orbit is very much thin, especially at the infraorbital foramen. So any infection within the maxillary sinus, they can spread into the orbit through this infraorbital foramen. Coming to the floor of the maxillary sinus is formed by the alveolar processes of the maxilla and the hard palate. In the children, the floor of the maxillary sinus will be lying at the same level as that of the nasal cavity, but it lies 5 to 10 mm below the nasal cavity in case of adults. So it is separated from the sinus by the thin lamella of the bone, which is dehiscent most commonly. So the root of the first and the second molars will be corresponding to the floor of the maxillary sinus. So this is the root of the molar, which will be corresponding to the floor of the maxillary sinus. So any infections over the root of the molars can easily spread into the maxillary sinus through the floor of the maxillary sinus. So there are certain anatomical variation, and the most common anatomical variation is the presence of the Haller cells. The Haller cells is otherwise known as the infraorbital cells. So what are these Haller cells? They are the pneumatized anterior ethmoidal cells that are projecting along the floor of the orbit, and these cells, whenever they are infected, they can impair the drainage of the maxillary sinus. So this is the CT scan showing the paranasal sinuses, and this is the Haller cell, which is most commonly situated over the maxillary sinus, and it is called as the infraorbital cells because it lies just inferior to the orbit. So any infection within this infraorbital cell or within this halar cell can impair the drainage of the maxillary sinus, ultimately resulting into maxillary sinusitis. So next, coming to the ethmoid sinus. Ethmoid sinus is also referred to as ethmoidal labyrinth. This is situated in the anterior skull base, and this is located exactly lateral to the olfactory cleft and the olfactory fossa. So these are the multiple ethmoidal cells which are present bilaterally, also known as the ethmoidal labyrinth. And this is the crista galli, and this is the cribriform plate. Just lateral to that is the olfactory cleft or the fossa, and ethmoidal cells lie adjacent to the olfactory fossa. So the width of the ethmoids increases from anterior to posterior because of the cone-like structure of the orbit. So coming to the boundaries of the ethmoid sinus, the lateral wall is formed by the orbital plate of the ethmoid, also known as the lamina papyracea. So this is the CT scan showing the ethmoid sinuses bilaterally here. So this is the ethmoid sinus, and this is the crista galli. This is the cribriform plate, olfactory fossa. So if this forms the ethmoid sinus, the lateral wall of the ethmoid sinus will be formed by the lamina papyracea here. This is the lamina papyracea. So lamina papyracea, in some patients it could be dehiscent. So any infections involving the ethmoids can spread into the orbit through this lamina papyracea wall. So any infections within this ethmoid sinus can easily spread into the orbit because of the thin wall of the lamina papyracea. In some individuals, this lamina papyracea will be very much dehiscent. Coming to the roof of the ethmoid sinus is formed by the frontal bone anteriorly, known as fovea ethmoidalis, and by the face of sphenoidal and the orbital process of the palatine bone posteriorly. So the transition of the thick fovea to the thin portion of the roof of the ethmoid medially is very much weak. So this weakest portion will be prone for the CSF leak during any injury to this foveal area. So this is the fovea ethmoidalis. As it moves medially, this portion will be very much weak. So any injury to this weakest area can result in CSF leak, resulting in CSF rhinorrhea. So ethmoid cells are divided into two groups, the anterior and the posterior ethmoidal groups. The anterior group of the ethmoidal cells drain into the infundibulum of the middle meatus, and the posterior group of the ethmoidal cells drain into the superior meatus. Sometimes the middle turbinate contain an air cell known as concha bullosa. This will impede the drainage of the middle meatus, resulting in ethmoid or the maxillary sinus infections. So this is the coronal section. This is a CT scan taken in a coronal section. So here you can see the maxillary sinus, and this is in the nose. You can see the septum which is deviated towards the right side, and you can see the turbinates bilaterally. The left side turbinate is more hypertrophied compared to the right side, and here the middle turbinate is also hypertrophied, and you can see a pneumatized area within the middle turbinate. This is known as the concha bullosa. So any pneumatization that is found within the hypertrophied middle turbinate is known as concha bullosa. If this is present, this can impair the drainage of the middle meatus, resulting in the respective sinus infections. Next, coming to the agar nasi cells. Agar nasi cell are another common anatomical variation. So it is nothing but the large ethmoidal air cell which is present anterior to the anterosuperior attachment of the middle turbinate. So these cells, they lie proximity to the frontal recess area, and they can impede the drainage and ventilation of the frontal sinus. So this is the CT scan taken in coronal section showing the agar nasi cell. So if this agar nasi cell is infected, it can be enlarged and it can impair the drainage of the frontal sinus, resulting in frontal sinusitis. Next, coming to the halar cells, as I discussed before, it is nothing but the infraorbital cells or anterior ethmoidal cells, and any enlargement of these cells can impede the drainage of the maxillary sinus. Next, coming to the Onodi cells. Onodi cells are the posterior ethmoidal group of cells which are located superolateral to the sphenoid sinus. Yeah. Yeah, this is the CT scan taken in sagittal section. This is the frontal sinus, ethmoidal sinuses. These are the posterior ethmoidal sinus, and this is the sphenoid sinus. This is the onody cell, which is just located superolateral to the sphenoid sinus. This is the endoscopic picture where you can see the sphenoid sinus ostium here, and the onody cell is located just superolateral to the sphenoid sinus. So these cells, they lie laterally close to the optic nerve, making the optic nerve at risk during the surgery within the sphenoid sinuses. If this cell is large, carotid artery could be seen bulging from its posterior wall. Next, coming to the frontal sinus. So frontal sinus is one of the sinus that shows the maximum variation. It can be absent in 5% of the individuals. It is more or less L-shaped, and posterior wall corresponds to the anterior wall of the anterior cranial fossa. So this is the frontal. This is the CT scan of the PNS taken in coronal view. A coronal section. So these are the bilateral frontal sinuses, which are more or less L-shaped, which is separated or divided by the interfrontal septum, and this is the sagittal section. This is the frontal sinus. This is the anterior wall and the posterior wall of the frontal sinus. So the floor is formed by the upper parts of the orbit. So this is the orbit here. The floor is formed by the upper part of the orbit. The floor of the frontal sinus is formed by the upper part of the orbit. The frontal sinus appear very late in life. The sinus drains into the middle meatus through the frontonasal duct. So there is something called as types of frontal air cells. There are 4 types of frontal air cells. The type 1 is the single air cell which lie above the agarnaceae. Type 2 are the series of air cells that lie above the agarnaceae but below the orbital roof. Type 3 extends into the frontal sinus but is contiguous with the agarnaceae cell. And type 4, the frontal cell lies completely within the frontal sinus. So this is the agarnaceae cell, and this is the frontal sinus with the frontal ostium here, and above that is the frontal infundibulum. As you track below, the frontal recess will be seen. Okay, this is the drainage pathway of the frontal sinus. So any infection or any enlargement of the agarnaceae cell here can block the frontal sinus drainage, resulting in frontal sinusitis. Next, coming to the sphenoid sinus. This sphenoid sinus is located within the skull base at the junction of the anterior and the middle cranial fossa. The pneumatization of the sphenoid sinus starts during 4th year of life and they get completed by 17th year. They vary in size and they are asymmetric in shape. So as I have shown you people in the previous slides, these are the sphenoid sinuses with the onody cell present superolaterally to the sphenoid sinus. This is the anterior clinoid process. So this sphenoid sinus is divided by the intersinus septum, and this intersinus septum is not exactly in the midline. They drain through the superior meatus. The structures that are related to the sphenoid sinus are pituitary gland above the sinus, optic nerve and the internal carotid artery traverse the lateral wall, and the nerve of pterygoid canal will be lying within the floor of the sinus. So there are certain types of sphenoidal cells depending upon the extent of pneumatization within the sphenoidal sinus. There are 3 types. One is the conchal type, second one is the precellar, and the cellar type. Cellar type is commonly present, seen in 85% of the individuals. Coming to the histology of the sinuses, paranasal sinuses. They are lined by the respiratory type of the pseudostratified ciliated columnar epithelium. The epithelium is composed of four types of cells: ciliated columnar, non-ciliated columnar, goblet cells, and basal cells. The mucous membrane of the paranasal sinuses has numerous mucoserous glands and the goblet cells, and this paranasal sinus has got the mucous blanket, which is composed of two layers. One is the inner thin serous layer, otherwise known as sol layer, and the outer viscous mucus layer, otherwise known as the gel layer. The cilia helps in the drainage of the mucus, which is more marked near the ostium. The mucus secretions of the paranasal sinuses travel in a spiral manner towards the ostium, and cilia are abundant near the ostium. They help in propelling the mucus towards the meatus and ultimately into the nasal cavity. Maxillary sinus drainage. The drainage of the maxillary sinus, the secretion transport is in a stellate pattern. The secretions transport will begin from the floor and they go along all the four walls and they come towards the roof and they finally converge at the natural ostium. This is not the floor, sorry, this is the roof. And they finally converge near the natural ostium and they drain towards the meatus and then they drain into the nasal cavity. Next, coming to the lymphatic drainage, they form a capillary network within the mucosa. They drain into the upper deep cervical nodes directly or through the the lymphatic drainage, they form a capillary network in the mucosa. They drain into the upper deep cervical nodes directly or through the lateral retropharyngeal lymph nodes indirectly. Coming to the blood supply, the paranasal sinuses are supplied both by the external and the internal carotid arteries. The external branches are the facial and the spinopalatine arteries, and the internal carotid artery branches are the anterior and the posterior ethmoidal arteries. These anterior and posterior ethmoidal arteries are in turn the branches of the ophthalmic artery. Next, the important feature is here is the septal branch of spinopalatine artery. They pass across the inferior aspect of the anterior surface of the sphenoid sinus. So when we are doing any surgery near the sphenoid sinus area, like for example endoscopic sinus surgery or spironectomy, this branch can easily be damaged, resulting in resulting in severe bleeding. Nerve supply. It is supplied by the ophthalmic division of the trigeminal nerve and maxillary division of the trigeminal nerve. Coming to the physiology of the paranasal sinuses, it has got the multiple functions. First thing is it helps in the humidification and warming of the inspired air, and it helps. It keeps the nasal chambers moist. It gives the resonance to the voice. It also helps in protecting the delicate structures in the orbit, that is the eye, and the cranium, that is the brain. It helps in lightening the skull bone. It helps in the rapid growth of the face. It helps in the absorption of the shock to the face and the skull. It increases the area of the olfactory membrane. It also helps in the regulation of the intranasal pressure. So coming to the ventilation of the sinuses, the ventilation of the sinuses takes place through their ostia. It is paradoxical and it is reverse to the lungs. The sinuses get emptied during the inspiration and they get filled during expiration. The inspiration causes negative pressure in the nose and the expiration causes positive pressure in the nose. This will help in setting up of the eddy currents that helps in ventilates the nose.
நான் கிளாஸ் போயிட்டு அப்புறமா சொல்லு.
Thank you. Do you have any questions? You can put up in the chat box. Yeah, when is the practical? Yeah. Yeah, regarding the practical test, it will be conducted on July 3rd. It will be in the form of Google Forms. You'll be given some 20 questions and you should be able to answer those 20 questions. So it will be held on July 3rd on Friday. Any other questions? Okay, if there are no questions, we'll wind up the class. Thank you for your if you have any questions regarding the topic, you can mail me. My email ID is kavya531990 @gmail.com. Thank you. ಇಲ್ಲ ಹೋಗ್ಬೇಕೇನಲ್ಲ? Stop recording.